would be saying is we can't afford not to. And I'm going to leave it at that.
That's a great way to finish it, Michelle. Thank you very much. That's a really thought-provoking and important presentation. I think that you've really pointed the way towards tackling some of the widespread preconceptions amongst health professionals. Our last presentation in the early afternoon is from Catherine Aldred, who's director of the IMPACT study and honorary lecturer at university. And Catherine is going to be talking about a series of projects and innovations linked to well, I'll let her talk about it rather than me. So please carry on, Catherine.
Hi, I'm Catherine Aldred. Thank you for inviting me to speak. I'm here on behalf of Professor Jonathan Green. So I'm going to talk to you about research trials that we've done, a series of trials that have been conducted over 18 years. And I want to talk to you really about our work currently on the implementation, how we weave the outcome of this research into practice, and how we can continue to conduct the research in its in a clinical base. So, you've got a full slide there. Fine. So this intervention is on an autism treatment called PACT. And as you may be aware that in autism, perhaps building on Michelle Briggs' presentation, there's been a lot of myths and legends around autism. And in fact, we started from a base where there were lots of interventions, none of which had been put under any rigorous test. Many intervention manuals have been published and been widely disseminated in the UK and internationally, for which there had been no evidence or research. It hadn't been put under test. And this did, would have consumed vast resources. And obviously there's a great drive from users to say, we need intervention. But following our research, I'm going to talk to you about how we've encouraged a change culture, moving away from the well-trodden pathway. So the first science was obviously about the etiology of autism. So the benefit is universally, internationally, there is now strong convergence in our understanding of what the core impairment is, what the etiology is, strongly genetically based, and other sort of where there are neuropathology underlying the condition, which has helped to make sure we've got high consistency, and it's also for just identification in the first place. And then we've had a picture for the last 20 years where we've had clearer definition of core symptoms, clearer characterization, better measures as a result of the scientific evidence. However, interventions were lagging far behind. In fact, we've had in many services, we've had a picture where people have said, we'll do the diagnosis because we have the diagnostic tools, and then we don't do treatment. And obviously this was a very unsatisfactory situation. What it led to was users, families going off, seeking for themselves some very diverse, non-conventional, wide, diverse range of interventions. So the question was, as we were conducting our research into intervention, and this was not published for 18 years until it had gone through successive trials, starting with a large grant from an MRC grant, and also then disseminated in international research in different cultures and countries, but also feasibility studies in the NHS. And you may be aware of a publication in the BBC recently about very early intervention with toddlers. What we did find was there's some key principles which we needed to apply in our NHS provision. So identifying the individual profile, the specification of that intervention based on individual need and reacting to it. and replacing some of the holistic, generic, non-evidence-based interventions with interventions which could be very targeted, so we could achieve optimal case management. And ultimately, we were wanting to prevent crisis, because we know that for many children with autism, the long-term outcome is that the complexity increases and we get into a crisis situation. So it was, how can such intervention science enhance our service provision? And I was working on this project both at the University of Manchester as a researcher, but also simultaneously in clinical practice. And now we're doing a lot of training around the implementation. So the aim for the health service provision is a more integrated detection and response. And we want to aim towards more family inclusion, user inclusion, so that we have things more online, from symptom monitoring to case management, stepping up to specialist service provision within integrated autism teams. And by disseminating research, the aim is for a more uniform access to intervention across NHS health systems. So from our research, this is a sort of pathway that was identified from research, and we were able to feed this into recommended practice, national recommended practice, and also NHS England funding now recommends this practice. And instead of moving the health system away from a watch and wait, see if the child matures and grows out of it, waiting, and we're in a current situation of waiting lists for a diagnosis, we were able to provide evidence that early intervention was key, intervening from the first concerns, from that early detection, and simultaneous intervention alongside the diagnostic process, and then having some core treatments for co-occurring needs and case management where that's required. So this is how we're doing. So we've got a manual, which is process driven, and we have a training package, and we have been working on these implementation trials. To date in the UK, we've made progress in Greater Manchester, Peterborough, Cambridge, London, Warwickshire, Newcastle. So if we just look at this pie chart, the red is the UK. About 18 months ago, the red was the size of Denmark. We had very few healthcare trusts that were taking up training and implementation. By support from commissioners in individual trusts who have been given generous grants, and then NHS England giving grants, we have been able to extend the UK training to about 25%. We've actually trained 757 professionals globally. You'll see it's very big in France, because France has a model where they have a 6-monthly report on evidence-based practice, and services are expected to follow the evidence base, and they receive funding if they do. So that was very easy to implement in France. But you'll see other countries such as Turkey, Saudi Arabia, Germany, Australia. So we've been training globally. As we deliver training, we encourage implementation trials where we do feasibility studies in both the NHS, education and caregiver settings. And we've had an implementation trial in low economic settings, for example, India and Pakistan. And through that implementation, we've looked at cultural adaptations. But actually, it's remarkably similar. Globally, the presentation of children with autism is remarkably uniform, and its impact on families. But what we have been able to do is look at these adaptations. So for example, in India, the context in which we deliver it and the scaling up of that intervention to make sure it's widely available and those hard to reach populations. So to explain a bit about the evidence, this is the most robust evidence of long-term improvement. And in these trials, we've been able to do not just short-term trials, we've done follow-up. And we have strong evidence that those children that received the intervention compared with controls had long-term gains. So the gains were remarkably sustained and maintained even after we'd stopped the treatment, and there were better outcomes 6 years later compared with those children in the control group. Through research, there have been developed manualized protocols, and this is quite important because many interventions do not have a manual protocol, and within that the research could retrospectively look at mediating variables. So we could, in our intervention, apply different emphasis, prioritizing aspects of the intervention, which was proven to be strongly predictive of the pathway that children were following. And within the manual, there are inherent measures, for example, using video. And through the research, we were able to look at how versatile this could be, moving towards online delivery in combination with live therapy. This makes it much more efficient, and we can scale it up more easily to a wider range of families. It makes it also more efficient for professionals. And we looked at this generalization context, how we could generalize those outcomes into the child's environment, that's the home and the education context. So the benefits, I think my role is going out now, visiting managers, service users, commissioners. We're approaching it from the bottom up and the top down to explain the results of this evidence, to ask services if they would be involved in pilot trials for which we already have funding, so we can fund posts and we can fund training, and we're offering it so it's for free. And we have to go out and really sell it, because we're still meeting a sort of a lack of understanding of what research is, what evidence is. Some services would still be saying, well, we do it this way and we always have done. So we have to really say, what's the added value? And I think this is quite key, and then start small and aim to grow big as we weave it into the service. And putting forward the benefits of pre-diagnostic intervention, enhanced experience of the care pathway, inherent outcome measures, so that those outcomes are very targeted and measurable. Increased efficiencies, the skills that professionals will gain, which is an enhancement to their existing skills. The sort of move towards a completely different concept from a sort of fix the condition to one which is about better understanding self-management, efficacy and adaptation to the individual. Something that is very much supported by adults with autism who are promoting the autism identity. And the cascade techniques that instead of being a drop in the ocean, how we can transform adult skills in the child's daily environment. And then gathering professional feedback. So professionals saying it gives me a structured individual pathway to intervention. So it builds confidence in professionals that they are following the best protocols. So how do we achieve NHS objectives? Well, measurable outcomes. And this is an area where there were very few measures before, but we now know the video is an extremely accurate measure, and it can give us very specific information. Professional fidelity, training to high adherence to the protocol. Scale up and efficiency, we can look at skill mix and to assure services that they are following recommended practice. So this is the training protocol and our manual. And I just want to thank you for inviting me to present. And these are the emails and the websites.